Therapies, modalities, DME. The record will include all DME modalities, therapies, perform the rationale for each, duration of each, and areas of application as applicable. Substantiate the therapies, modalities, DME that are consistent with the patient's chief complaint, clinical findings, diagnosis, and treatment plan. And if time-based therapies are performed, the record will reflect the actual time the therapy was performed. Remember when we'd spend an hour talking about time-based therapies? You know, 5-6 years ago now, everybody gets it and what it takes to do that. I go to other states and we spend an hour talking about time-based therapies and exactly how to do that. So I'm grateful that we are so much further ahead. During the initial phase of care, no more than 2 therapies or modalities per visits are considered usual or customary, and there should be a reduction in the number of therapies as the patient's condition improves. So you may add things, you may start out with stem and ice to begin with. Maybe you're going to go to intersegmental traction, maybe you're going to go to ultrasound, maybe you're going to go to laser, whatever it might be. You're going to add those things, just explain those things along the way. Re-exams. When? Re-exams must be performed approximately every 4 weeks or 12 visits, whichever comes first. Notice the word approximate. So this is what somebody said to me before. Well, listen, Dr. Sharp, you didn't do a re-exam for 6 weeks on a patient when they were looking at some notes or something like that. The reason is I'd only seen them twice in that 6-week period of time because we had 2 or 3 times because we had spread that course of care out. So again, when you're seeing that patient on an active basis, you want to be really strict with that, keeping up with that. But typically, towards the end of my treatment, I may see, hey, listen, we're going to wait 2 weeks. I'm going to see how well you do, and then you come back. So you may be 5 weeks for that particular patient, but clinically it makes sense. So again, put some thought into it, because again, we want good, valuable information. Re-exams, if properly done and properly documented, provide objective evidence of the patient's progress towards treatment goals, determine the effectiveness of treatment to date and whether treatment should be continued, modified, or discontinued, and help to determine the appropriateness of additional care that can be billed to the payer. And of course, determines when MMI has been reached. Let's talk about it. How many of you look at your CPRs and look at that kind of target, or kind of, what's the word I want to use? Target for the number of re-exams that you do. How many of you look at that? Okay, not many of you. Let's put a big red circle around that. Things to do on Monday is really look at, we just got a CPR in the last few days. So pull that out, read through it, and there's a section for each Blue Cross Blue Shield MedCost Cigna that kind of breaks down what they would expect, the number of re-exams that you had done on that patient, kind of see where you fall in that. Again, it's not a race to that number, but it gives you a good target and estimation of where you should be, all right? And I tell you, I'm going to put Dr. Bender, when you look at your CPR, because I know you look at your CPR, how close are you typically to that number?
Within 4 or 5.
Yeah.
Yeah.
Yeah, within 4 or 5. There we go. Yeah, we'll give him. That's good. Good.
Because of the algorithm, really, there's an expectation. While certainly, as you said, it's approximate, but with 20-some years of data, we would expect to see at least 90% of that target number. And this is, I think, really important. Unfortunately, even the doctors whose participation status is excellent, so they're in great shape, their cost per patient is good. When we look at those target numbers for the re-exams, many of those they're only doing them 10% of the time.
Wow.
Or if they are doing them, you're not billing for them. Shame on you, because that's a lot of revenue you're losing. Plus, it's keeping the networks benchmark down, okay? So not only is it important to do them, but you need to make sure you're billing for them.
Right, that's very good. I am typically within half a dozen You know, once in a while, be it maybe one or two over, but within half a dozen numbers of that. And again, it's not by, I don't sit there and think about it. I just do it as my natural part of what I do in my office, and that algorithm fits.
Well, while we're on that topic, you know, when we see a doctor's CPR with a high number of visits that might be above the network average, typically when we go to that section of the CPR, it's very skewed, where they're not showing they're doing re-exams at this level, and which means that they're not watching when MMI is reached accurately. Right. And so once we, Dr. Armstrong and myself, coach doctors on doing that, it's amazing how quickly their numbers normalize inside that CPR. So it's a big, along with treatment plans, that's probably one of the other major problems that we see.
Re-exam. Yes. Yeah. So the interesting thing, again, you know, the reason I encourage you to look at those CPRs is it really sheds light on what you're doing in your practice. And it is interesting, once you start looking at that, when I talk to a client that I'm going in helping them in their practice, one of the first things I want to see is their statistics. Because what they tell me is not what's really going on in their practice, so I see it from their statistics. And based on those numbers, you know exactly what's going on within a practice, how they're managing patients. It's pretty predictable. So use that information to encourage you. And if you don't understand how to use that to see how it actually affects or how you can improve your practice or how to apply it to your practice is the better way to put it, then I would expect they would call H&S and that they walk through that with you. And Dr. Binder and Dr. Armstrong have done it a few times. So, Dick, do you have anything you'd add to that? Or?
So much data now over years and years and years, 1,000 doctors in North Carolina, millions of office visits. So, you know, assuming that everyone is relatively close on their reporting accuracy, the other side of the data is the network data. And it is, and I try to stress this every time I talk to docs, it is so profoundly helpful. I mean, that data, because the data set has become so enormous, just gives you huge amounts of information. That isn't to suggest that you're supposed to practice like everyone else, but it does give you an incredible baseline as to what's being done in every chiropractic office, every network, H&S network chiropractic office in North Carolina. As I say, that's a lot of office visits.
That's great. Thank you. Thank you. And then again, outside of the clinical reasons and all that stuff, from a fiscal perspective, I mean, this is, again, we get paid for time and services. So the Board of Examiners are requiring us to do these. The payers are requiring us to do these, and they actually are going to pay for these. I will tell you, Blue Cross Blue Shield of South Carolina does not pay for re-exams. They do not get paid for re-exams. Our contract is different. And so we have that access to do that. So take advantage of that, number one, from a clinical perspective, but from a financial perspective, making sure you're doing that. So if you were to add, just think about it from a money perspective, a re-exam, I don't know, let's just say $30 or $40, whatever, let's say 30. If you were doing 10 of those a week, that's $300 of added revenue times 50 weeks a year. You know, that's thousands and thousands of dollars being paid for something that you're required to do to make good clinical decision making. So again, you can look at it, you know, when I like to talk about this subject, I also like to talk about the revenue payoff on this. So you want to start doing that. So staff, this is where I'm going to put you under the microscope a little bit. Make sure that your doctors, when they're doing those evaluations, that they're coding for those. They don't get in trouble for that. They actually get in trouble for not doing that. So you want to encourage them with that as well. Okay? Good. All right. Re-exams, the documentation of all re-exams performed, indicate any tests performed and the results of those tests, all clinical examination findings, objective and subjective, and include sufficient documentation to substantiate the specific level of E&M code reported. We're talking about those 99211, 212, 213, 214, 215. We should never be doing anything less than a 99212 code when we're doing these re-exams, docs. All right? And vitals must be obtained during each re-exam, and results must be documented in the healthcare record. So that's important as well. So staff, this is, if you're doing the vitals in your office and you're not doing them at re-exams, this is one of the things you need to do. Figure out how and when you do those. Do you take the patient for the re-exams into an exam room? Well, then that makes it easy. You just do the vitals then. In my office, I do my re-exams in my treatment room, so it's a little different. So my staff has to go out of their way, take the patient in to the exam room, do the vitals, do therapies, bring them into me, yada, yada, yada. So it's a little bit more awkward. So kind of figure out how you're going to do that. And then the other thing is staff, when your doctor makes that policy, then you implement that policy. So it does automatically. You don't need to go up and say, you know, Dr. Sharp, do I need to do vitals on this patient? The answer is yes. It's a re-exam or a progress exam. You're going to do vitals, so get that done. So it's not sufficient to merely perform and document the re-exams, but at each re-exam, results of OAs that the re-exam, the outcome assessments from that re-exam must be compared to the initial and previous OAs. Objectively measure patients' progress towards treatment goals to determine the effectiveness of treatment provided and determine when MMI has been reached. The clinical record must include a summary assessment of the outcome of this evaluation. All right? Again, it needs to be very simplistic. It doesn't need to be a dissertation, but it needs to be outlined and put into your record. Again, at each re-exam, results of the OAs from that re-exam must be compared to the initial and previous outcome assessments to objectively measure patients' progress towards treatment goals, to measure the effectiveness of treatment provided, and determine when MMI has been reached. Okay? If we said it once, we've said it 1,000 times today. And then, like we've already been talking about, always bill for those re-exams. Re-exams performed pursuant to H&S policy every 4 weeks or 12 visits, whichever comes first, should always be reported using the applicable E&M code. Very important. All right. All right, medical necessity. So this is where we start to kind of tie things together, kind of gone through a lot of the details of the day. We start to kind of move in a little bit different direction. So again, what does medical necessity? I always hated to get that letter from the insurance company saying you lack medical necessity. Now that I'm looking back 15, 20 years ago, man, I provided nothing for those patients or for those carriers except arrows and good gestures. So now we have to do more in documentation. So it's defined by the Department of Insurance. It means that those covered services or supplies that are provided for the diagnosis, treatment, cure, or relief of a health condition, illness, injury, or disease, and except as allowed under this statute not for experimental, investigational, or cosmetic purposes. It's also necessary for the appropriate to the diagnosis, treatment, cure, or relief of a health condition, illness, injury, disease, and or its symptoms, and within general accepted standards of medical care in the community, and not solely for the convenience of the insured. Let me say that again. Not solely for the convenience of the insured's family, or the provider. For medically necessary services, nothing precludes an insurer from comparing the cost effectiveness of alternative services or supplies when determining which of the services or supplies will be covered. So as a general rule, insurance plans only cover medically necessary chiropractic care as defined in its corporate medical policy. So not all clinically appropriate care meets the payer requirements for medical policy. As physicians reporting certain health care plans, we are required to know and comply with their CMP, including how they define medical necessary care. And payer CMTs are posted on the website, so you can look at those. That is unusual to be able to access those. Not all states allow you to access that They certainly don't make it available. If you've never looked at Blue Cross Blue Shield's medical policy, for example, if you pull that up, at the end of that, anytime they've changed that policy, it is dated and what the change was to that policy. So it's very interesting to look back and see some of the changes over the last 15, 20 years. Really hasn't been a lot of change at all. We can argue things, but significant changes has not occurred. That's been very protected here in North Carolina. That's a very good thing. So from Blue Cross Blue Shield, their corporate medical policy in part states chiropractic services are medically necessary when all the following criteria have been met. You would read this. The patient has clinical symptoms of a condition that may be improved or resolved by standard chiropractic therapy. A clear and appropriate treatment plan is documented, including symptoms, diagnosis being treated, diagnostic procedures, and treatment modalities used, results of diagnostic procedures, treatments, anticipated lengths of treatments, and quantifiable, attainable treatment goals. This is their corporate medical policy. The chiropractic diagnostic procedures, treatments are clearly related to the patient's symptoms and conditions, and manipulation and modalities must be consistent with the patient's chief complaint, clinical exam findings, diagnosis, and treatment plan. So when chiropractic services are not covered in the following circumstances: services beyond benefit plan visit limitations, or services that are excluded from the benefit plan; vertebral axial traction or decompression, including computerized decompression devices designed to provide mechanical traction; and electrical diagnostic, EMG, and nerve conduction studies unless rendered by a chiropractor or certified chiropractic neurologist; and kinesiotaping. Therapeutic manipulation modalities that are not clearly related to symptoms and or diagnostic x-rays, or that are not likely to result in long-term improvement of a member's symptoms or condition. And then also the following therapeutic modalities: counseling considered integral to the visit, and low-level laser or cold laser is not a covered benefit. And for most plans, then maintenance programs or supportive care would be a non-covered service as well. Okay? Any questions on those things? Okay. So, boy, I could tell you stories about what doctors think about support or covered care. So, a lot of docs think if I bill it and I'm being paid, then I'm fine. Okay? So you're billing CPT codes for maintenance care, I get paid, so I'm fine. That is not the case. You still need to be able to show medical necessity for every service you provide. So let's say you're going to do cold laser. Okay, so let's go outside of into a non-covered service. If you're doing cold laser in your office, you still need to substantiate the need for care. Well, it has nothing to do with what Blue Cross Blue Shield or H&S or Cigna or whoever says. You need to clinically justify the need for cold laser or kinesiotaping or whatever it might be. Any type of DME or non-covered service still needs to be in your notes. It needs to be explained, and it needs to provide some improvement for the patient's condition. You know, I have a saying: if you're doing something in your office with the primary reason of making money for it, you're probably headed in the wrong direction in your office. There are so many things that we can provide in our office that are covered in non-covered services that help our patient. Those are the things you need to be focused on. So what is supportive care? Let's move into that. So to comply with H&S and payer CMTs or CMPs, and to ensure the providers accurately and timely determine when MMI has been reached, we must have a clear understanding of what supportive care is. Supportive care, by definition of the ACA, is treatment or care for patients who have reached MMI, maximal therapeutic benefit, but who fail to sustain benefit and progressively deteriorate when there's periodic trials of treatment that is withdrawn. Supportive care follows appropriate application of active and passive care, including rehabilitation and/or lifestyle modifications, and supportive care is appropriate when alternative care options, including home-based self-care or referral, have been considered and/or attempted. Supportive care may be inappropriate when it interferes with the other appropriate primary care or when risk of supportive care outweighs its benefits, i.e. physician, treatment dependence, somatomization, illness, behavior, or secondary gain. So with few exceptions, supportive care is not covered by insurance. There are a few plans here. We're in the triangle. There's certainly some folks that do cover that, and that's great. But for the most part, it is an uncovered service. And let me just talk outside of the H&S plans. Medicare, we all want to be reimbursed for exams, x-rays, PTs with Medicare. One of the major reasons we are not being fully reimbursed with Medicare is not the ACA or the ICA or whoever that CA is. It's because chiropractors continue to bill for maintenance therapy for their Medicare patients. So whether you're doing it with your H&S patients or with your Medicare patients or whatever, set those standards in your office. Make sure you're releasing those patients and putting them on maintenance care. Yes, do some people leave? Absolutely. Do some people stay? Absolutely. And that's not your decision to make for the patient, that's the decisions of the patient to make for themselves. Your decision is to follow the corporate medical policy, whether it's a commercial carrier or whether it's Medicare, that's your obligation for the patient. So what is MMI? Maximum medical improvement occurs when a patient with an illness reaches a state where additional objective measurable improvement cannot reasonably be expected from additional treatment, and or when a treatment plateau in a person's healing process is reached. In its simplest form, MMI means that additional treatment is not likely to produce additional functional improvement. And this is not to say that the patient may not regress in the absence of further care, but if so, treatment would be supportive, which is not covered by insurance. So again, this is the key. You've got to get out in front of this. Make sure it's very clear for your staff. And staff, I know the pushback is with you, right? The doctor, he or she, goes back into their treatment room and shuts the door, and I'm stuck holding the bag, right? I've got to explain to the patient what supportive care or maintenance care and why it's not covered by insurance. There's a way to do that in your office that takes the pressure off the staff, off the doctor, and it's much more. We'll talk about that today. But it makes it a much more seamless progression as the patient goes through the office. But make sure you're releasing those patients from active care, getting them to a supportive mindset. It's not just continued active care once a month. It is a different type of care, and you articulate that to the patients, and they're more likely to respond in that way. So comparison of results from OAs done at the initial exam to the results of the OAs at the subsequent re-exams is necessary for determining when MMI has been reached or not reached, for that matter. Again, it's not based on the number of visits. H&S only wants me to see a patient for X number of visits. It's based on what's medically necessary for the patient. All right? If you have not initially established a reasonable, objective, measurable treatment goals, you can't objectively evaluate treatment effectiveness. So it's up to you. If you aren't measuring patient progress towards treatment goals and effectiveness of treatment using those outcome assessments via re-exams every 4 weeks or every 12 visits, you will not be able to objectively determine when MMI has been reached. So you've got to be doing that. So when the patient has reached MMI, this information should be communicated to him or her. What to say? While continued care is recommended, we have reached the goals of your treatment, and additional care is not likely to produce additional functional improvement. I don't think I could say all that to a patient. I'm not that articulate, but it's the thought here. It's the process, letting the patients know that they're moving to a different stage of their treatment. So as soon as MMI has been reached, the patient must be released, referred, or switched from active care to maintenance and supportive care, and those visits must not be billed to the payer. All right. So let me talk about this for a second more, if I can. And because this is the one thing that I get a lot of pushback on, particularly from your staff, is they are up there arguing with your patients over their insurance benefit. If that is happening in your office on a consistent basis, you're not educating the patient clinically well enough to make that fiscal change, that insurance change, shall we make. So we talk a lot about, for instance, we talk a lot about healing in the office. I try to stay away from benefits, number of visits. I don't talk to my patients about that other than setting those expectations up at the beginning, kind of giving those estimates. So we let the patient know from the first day that I have a little saying, I see if I can remember it. After we've kind of explained generally what we're doing, we're about ready to look at their x-rays. We look at the spinal chart, and I say, so my objective is to correct the spine the best that I can, so it heals the best that it can, so you feel the best that you can. So I don't tell them we're going to fix it. I'm not going to tell them that they're going to be asymptomatic. We're going to provide the best care, get it to correct it the best that we can, so it feels the best that you can. So it begins from the second day in the office. We're setting the expectations of improving their spine as good as they can. So then when we look at the x-rays, we have that premise. When we look at this, you've got pretty significant degenerative changes. We cannot regenerate discs. This is a chronic problem. Right now you're having an acute flare-up of this chronic problem. So what does the patient say? Well, I've never had low back pain in my life. And you see these undulating spurs that are coming down, their lumbar spine and degenerative disc and what have you. So you say, well, you're very lucky then, but this is what's going on. This has been deteriorating over to a time when we finally come to the point where we broke the last final straw that's broke the camel's back. Not that you look like a camel, and then we go through the process. So what we've got to do is, this is just like any other chronic disease. We've got to stabilize this the best that we can. You with me now? We've got to stabilize this the best that we can so we can get you feeling the best that you can. And then when we're done at the end of your active care plan, we're going to have to figure out how to manage this going forward. Things that you'll do outside of the office and inside of the office. But we don't know those things yet until we've gone through this initial acute care. So is that honest or what? So we're saying that on the second day and letting them know. So by the time we get to that progress exam, so what do you say if the patient is completely asymptomatic after 10 visits? But they have functional deficits still present. So sometimes they can be pain, but they can't bend down and put their shoe on still, but they're restricted, or maybe there's tightening of that hamstring or whatever it is because of the injury. So if you're based just on pain, then you kind of lose the mojo, you lose the leverage, because what you want to do is get the patient's condition to heal and stabilize. Now, if that happens after 10 visits, terrific. We MMI them and we move them on to maintenance care or supportive care. That's great. But if we still have some work to do, then you've got to be able to articulate. So if everything's based on symptoms, they don't understand why you're going to need to do additional care. So what we also don't want to do is have patients come in for 6 or 7 visits, become asymptomatic, and 3 months later come back in for 6 visits, then be asymptomatic and come back in another 6 months. All of a sudden, you know what, that patient, that's how you get a 25-visit annual care plan for a patient, is because you've never taken them through a full course of care. They've been incompliant or uncompliant with their care. Or maybe you just didn't give them an extended care plan. So once you can get them stabilized, that's when you can make those long-term recommendations. But along the way, you're talking about it with the patient, so they're expecting that. As part of your care plan, when you get to the end of it, they're MMI. Now let's start focusing on the long-term chronic care. Okay? Any thoughts? Anything you'd like to add to that, Dr. Bender? No? Good. All right.